Good morning, and thank you, Dr. Chen, for introductions. May I have the first slide, please? So this morning, I'm going to share with you my observations on science and politics of the SARS-CoV-2 pandemic control policy, and by giving some example from the United States. And perhaps United States, particularly early on, show us a negative model, kind of negative model, what not to follow. So my presentation include 5 short parts. So first, I will talk about the prelude to the pandemic, and then the 2 phases, the pre-vaccination phases and post-vaccination phases. And that follow with the challenges we face, not just unique to United States, but United States probably exhibited a more extreme form, but many other countries also experienced. And then lastly, a brief conclusion on lessons in the future. So one of the important message I've been sharing since the beginning of the pandemic was this pandemic could have been averted. And unfortunately, I was the lone voice. I repeatedly, whenever I had chance, I was interviewed by the national and international media for over 350 times during the pandemic. Whenever I have chance, I repeatedly emphasize this pandemic could have been prevented. So we have to learn what went wrong. And one of the things went wrong was we didn't learn the lesson adequately from the SARS 2003, because the early phase of development of the COVID-19 were almost identical to SARS. And the reason we didn't learn the lesson from SARS was what happened to us. So this was an important message I'd like to emphasize. And the example I'd like to give, many of you are probably familiar. To date, the worst industrial accident happened in Bhopal, 1984. The methyl isocyanate gas leaked from the chemical pesticide factory. And before they built that factory, there were lots of concern about building such a high-risk factory amid the urban center with large population. But the Union Carbide who built that factory assured the government that accident like that is 1 in several million because they built in 3 redundant safety devices. So the 1 in a million probability of leak or accident is all 3 safety devices have to fail at the same time, which is nearly impossible, but it happened. And I use this as an analogy to why I keep emphasizing this pandemic could have been averted. So similar with the Union Carbide, we have 3 safety mechanisms. First, the warning from country of origin, and the member state of WHO has an obligation since the 2005 revision and expansion of international health regulation. But what I mentioned, the early phase of development were identical to SARS because it's the same country of origin who initially not disclosing the nature of infection. So our first safety devices failed in this case. That leaves us to the second safety mechanism, the World Health Governing Body, in this case, WHO. And contrast to the WHO in 2002 to 2003, that was more effective, more assertive. Unfortunately, the WHO leadership during 2019 to 2020 were no comparison to the leadership in 2002 and 2003. And so our second safety mechanism also failed. That leads to the last safety mechanism, each country borders. And that's how we see differences, variations in the result. So many of you are probably familiar with Liu Wenliang, the whistleblower, who identified something going on in December 2019 and sounded the alarm, but he and his colleague were punished. And eventually, unfortunately, Dr. Liu Wenliang also infected, and he died in February 2020. So those pictures I downloaded on January 18 to 19, 2020. That was before the source acknowledged the infectious nature of the disease, because repeatedly, as late as January 16, the International Press Conference of the Chinese government still declared, we have no evidence this disease is infectious. And this happened in January 19, the day before finally China acknowledged this disease was infectious. Wuhan held the world's largest potluck that accompanying the Lunar New Year. Over 40,000 people shared food in a large auditorium. Those people have no idea what kind of risk they were engaged in. Had they knew that there were already infections spread as early as November 2019, they would never help those potluck dinner. So I downloaded those pictures, but soon after China acknowledged, and then WHO a day later followed that, acknowledging this disease is indeed infectious, all those pictures of the potluck were taken down. So you can no longer search and find those pictures. And WHO was very slow to respond to the early spread of the disease. And it waited until March 11 to announce this is a pandemic. By that time, it was way too late. So I summarized some of the key issues, what went wrong that allowed this pandemic to happen, which we could have prevented it. And the one major failure in this case was the ineffectiveness of the World Health governing body, WHO, not being timely or effectively to declare the danger. And in the early months, the Wuhan wet market or seafood market were marked as a source, potential source of the emerging of the viruses. But that has been challenged by the Louis Pasteur Institute conference as well as its researchers, because they used the sample collected from that Wuhan market in December 2019. And in their analysis in spring of 2022, they found the meat that has the largest viral load were from pork, beef, and lamb, which is impossible to be the source of the coronavirus. And so they reversed the causal relationship, given that by 2022, there were already strong evidence this disease was already spreading no later than November 2019. So what we found, the viral load in the wet market, they were not the origin. They were shared by humans who were infected and who then visit the market to share those viruses, which is why they found there were more concentration and high dose of viruses among pork, beef, and lamb. And there are also heavy evidence, I call it 100% solid evidence, that the source already knew the infectious nature of this disease much, much earlier. And those solid evidence were provided by the publication in New England Journal of Medicine and other medical journals by Chinese epidemiologists. And the earliest sample collected in the reported paper was November 17. And you don't start collect sample unless you know there's something going on. So if the first sample was collected November 17, that means much earlier, those researchers already knew what's happened. So I remember in January, a week later, after China and then WHO announced and confirmed this disease, it was indeed infectious. And then immediately published the New England Journal of Medicine. There was some outcry from the, I have this paper. There was outcry from the scientific community to retract this paper for moral reasons, because those researchers, a large group of researchers, epidemiologists, they knew what's going on much early, no later than December 1st. But they kept it silent. Had they sounded the alarm, those people in Wuhan, they would not have held that over 40,000 people per lakh. And people in Wuhan and other areas would have much more time to prepare. And likewise, the world would have more time to prepare for this spread. So as we knew what happened, that phase 1 pre-vaccine, and this is what we know early on, and of course by now we know much better. And I have been keeping this timeline from the beginning of 2020, and I keep updating that of the key events happened in those timelines. And what's important is I arbitrarily divided into those phases is pre versus post vaccine, because for the post-vaccine, the significance of pandemic control strategy is not just the vaccine itself, but by that time, the scientific community have made a great discovery for both what's the better way to prevent as well as to cure or treat the COVID-19. So that represents a different stage of control. And also, early on, we have accumulated enough evidence that the fatality rate of infection are highly concentrated on the elderly, the older age. And for the younger age, where they have a higher preference, their fatality rate are much, much lower. And similarly, this was identified in different continents about the age distribution with relationship to fatality. So I summarized based on my observation, and this is somewhat arbitrary, of 4 types or models of epidemic control during phase 1. Sweden is in a group of its own. Its strategy was try to develop herd immunity. And what it didn't do well was, where it tried to achieve herd immunity, it didn't do enough work to protect its vulnerable population, particularly elderly, and resulted in a high fatality in the early months. And then most of the country belonged to the second group, slow responses. And the slow responses, partly, I attributed to WHO's slow responses. And most of the countries simply following the WHO guidance. And then the third group, United States as an example, it started with denial of the pandemic. Later I will show you the example. And the denial turned into even slower response, and that resulted in high fatality in terms of number or deaths per million. The last group are the countries like Israel, Singapore, Taiwan, South Korea, New Zealand, etc. They took very early actions in preparing for this pandemic. And particularly Taiwan and Vietnam and Singapore, they learned the lesson from the SARS. So those countries has been preparing for the next epidemic or pandemic since 2003. So they have a long lag time to prepare. And that resulted in very well an effective response early on. And I like to comment that Dr. Chen, our co-chair, at that time was the vice president of Taiwan. He was very instrumental in guiding Taiwan's pandemic control policy. And I observed throughout the pandemic, different countries experience peak of fatality a different wave, and which is a very complex reason why a country like USA and Canada and Taiwan, etc., and Germany, they had a peak of deaths per million, a different wave. And this is the variation we observe in the US in terms of cumulative deaths of COVID-19 throughout the pandemic. This is the cumulative deaths per 100,000 people. The third section, phase 2, the post-vaccine era. I'd like to briefly summarize some of the achievements in reaching herd immunity. So you're familiar with the Operation Warp Speed, and there's debate and speculation what motivated the Trump administration to initiate this more than $10 billion budget. And of course, there's a speculation, the reason why initially he denied the pandemic ever existed, but then why would he initiate this warp speed? And one speculation commonly shared was he's concerned about his re-election at the end of that year. And I will skip this one. So here's some of the key information about the Operation Warp Speed. And it involved many federal agencies, including the CDC. And earlier, Professor Graham already mentioned about the pre-pandemic work that the technology was already there, and they just need a boost of the investment. And this was in 2021, when the US rolled out the vaccination, they set the vaccination priority. And this is the cumulative confirmed deaths by world region. And as you can see, Europe and North America, South America, they accumulated a high percentage. And I have the percentage of the share of the population. So on the left legend, I calculated the excess COVID-19 deaths, the excess meaning the excess of their proportion of the world population. So for example, Europe has 21.5% excess in terms of its proportion of the world population. North America has 19.8, and then South America 16. The other continent actually has under share in terms of proportion to its population. And one interesting information was about Africa. Of course, Africa has an under testing of the COVID-19, but still, in terms of the excess deaths, Africa experienced the smallest per million deaths in all continents. And in 2021, I organized an international conference on the COVID-19 pandemic. And one expert in Africa provided this insight. The reason Africa has observed lower deaths per million in COVID-19 than any other continent were multiple. One was Africa has been fighting with numerous infectious diseases that make its system as well as a society more resilient. Second important reason was Africa has a much younger population. And from those evidence we know, the fatality of COVID-19 tend to highly concentrated in the older age. So because Africa is relatively young population, and that's another important reason they suffer less deaths per million. So in my analysis, I include 3 phases. The phase 1, the pre-vaccine, the phase 2, post-vaccine, and then the phase 3 is transitioning into the post-pandemic. And in each phase, it required different approach, different strategy to control the pandemic. And again, this is the world distribution of deaths per million of the COVID-19. I didn't want to compare the preference per million because, as you know, because it's a sizable asymptomatic infection that we never get to detect it. So the infection rate or the the preference is very difficult to estimate, but the test is relatively more accurate than the infection. And then by end of 2021, we have accumulated more evidence, and US CDC has conducted a large population study for over 6 months. So it took the population data of two largest states, California and New York, and observed those population data over 6 months. And in its conclusion, it reversed CDC's earlier statement in 2021. In 2021, when CDC rolled out mass vaccination, in its statement and promotion, it says the vaccine-induced protection of immunity is better than the natural immunity. But that was not based on empirical data. So after CDC collected this empirical data, it reversed. So it changed its statement, say the natural immunity provide stronger, better protection than the vaccine-induced immunity. But if you get both, you have vaccine-induced plus natural immunity, then you have the strongest protection. So this curve shows its data. And similar result also observed in Chile. Chile was one of the countries very early on had a mass vaccination, but its early mass vaccination was not very effective because it used a less effective vaccine from China, and later it has to revaccinate its whole population with Pfizer. But Chile tracked its data also show how vaccination can protect against severe symptom or death. So this was the CDC's revision of the protection, immunity protection. But this also shows how challenged it is in translating science into policy, because CDC for numerous times have to reverse its statement. And that sometimes gives people the impression that CDC or the government is not being upfront or not being accurate. But the general public don't have the sophistication of understanding that's the nature of science, that we base our policy on the current available evidence, but even though the current available evidence may turn out to be wrong, which throughout this pandemic, particularly the first year, many of the early evidence data turned out to be wrong. And the big game changer was the Omicron. So by December, two publications came out. First was by University of Hong Kong, and then, so this was by the University of Hong Kong, and then a large group of researchers between US and Japan confirmed the Hong Kong's finding that the variant Omicron, its reproduction rate in the upper respiratory tract was more than 10 times of the Delta variant. But at the same time, the virus reproduction rate in lung was less than 1/10 of Delta. So that gives the scientists the confidence. It has strong impact on two important policies. One is, given the Omicron's highly infectiousness and also immune evasion, it's unstoppable, that almost nothing can stop the spread of the Omicron. But at the same time, because its very low reproduction rate in the lung, that means it will cause far less damage on average compared with all previous variants. So it changed the policy. For example, US, UK, and several other countries, they no longer do contact tracing. Instead, they concentrated their effort and personnel to protect the vulnerable, the elderly, etc. So the fourth part, let me summarize some of the challenges. When the pandemic started, the Trump administration complained the previous Obama administration didn't leave any guidance for them. But immediately, at least 3 former Obama staff jump out to say, we did. So they actually transferred a 69 pages playbook of how federal government should respond. And that whole playbook, 69 pages, You can download from the website. And there's also a detailed report how the Trump administration totally neglected to follow those guidance left from the Obama administrations. And also the early on, for the first 2 months, the Trump administration mentioned a few times in the public speech saying this pandemic is a hoax, even though later he corrected himself. He said, I didn't mean the whole pandemic was a hoax. I mean the way the media blow it up is a hoax, not the pandemic itself. But unfortunately, many of his followers didn't catch the revision. They, deep in their mind was the initial announcement that this pandemic is a hoax. And by August, there was a survey among US population. And in that August survey, they found about 14% of the sample still think the whole pandemic is a hoax. And another 40% of the population survey think this pandemic is not as serious as the media has portrayed. So those are the people who will become reluctant or rejected wearing masks or get vaccinated, which help explain why US has such a low vaccination rate compared with other high-income countries. And one major study, they found cumulative age standardized COVID-19 deaths with interesting social demographic factors. And there's a trade-off during the pandemic between individualization of risk versus socialization of risk. Likewise, trading protection of personal privacy versus protection of public safety. And some of presented earlier already talked about, I will not repeat about those vaccine politics. And we are dealing with the misinformation and disinformation. And 2003 was the first time that term was coined, the post-truth era, by a sociologist. And I also summarized some of the challenges of politics of the COVID-19 pandemic control, such as solidarity versus division, political trust, and some of the other issues many of our colleagues mentioned earlier. But then I also highlighted the lack of or inadequate of global health governance. So lastly, some of the lesson in the future. Lancet Commission on the COVID-19 has a good summary. I highlighted 2 points. Number one, the lack of timely notification of the initial outbreak. This was what I repeatedly emphasized, that this pandemic could have been averted had we avoided that, number one. And then number 8, the poor enforcement of appropriate level of biosafety regulation in the lead up to the pandemic. That was related to a disputed issue of where the virus came from. And I also during the pandemic, create this chart to indicate the factors that will help us end the pandemic versus factors will intensify or prolong the pandemic. So the green part, such as the global international collaboration, solidarity, trust, etc., will help end. The bottom part, the pandemic nationalism and poor governance or individualism and social distrust will prolong the pandemic. And the pandemic also worsened the inequity, particularly in education. I remember in the summer of 2020, UNICEF came out to say, please do not close the school. The closed school will not work, particularly for the low-income country. And this was on the website, came out in that summer 2020. This is what remote education looked like in low-income country. Remote education is almost no education. And last year, U.S. has a study evaluating the remote education during roughly 1.5 years of pandemic, resulted in, on average, the K-12 public school student lost 1 full year of education. But the pandemic also enriched the super rich. This is across the board. The light blue was how the wealth concentration in the super rich. The dark blue was the increase of their wealth during the pandemic. One big question towards the end of the pandemic is, when do the costs of pandemic control outweigh the benefit? As early as summer of 2020, a survey in the US already found out that people by that time already more concerned about their livelihood than about the life and safety. So the orange bar were concerned about economic, the blue bar were concerned about health. So the COVID-19 has generated 3 related casualties. The direct casualty of COVID-19, the casualty from COVID-19 pandemic that's indirect because of the pandemic changed the social system and people behavior, but then there's a casualty from the policy itself. So this is the conceptual framework I developed. Last year, I conducted a 6-country comparison of pandemic control policies. So the government pandemic control policy directly affect social well-being, but then it also impacts the population's life and health as well as the economy. And this is a quote from the New England Journal of Medicine article about, do pandemic ever end, and who decide when the pandemic ends? And the world after pandemic are no longer look exactly the same, particularly the number 3, the divergence of globalization and localization, and there's a shakeup of supply chain. Also, the coronavirus challenge open democracy because during the pandemic, because the state of emergency sometimes turned into emergency state. And that happened in many democracies, which violated human rights and protection of individual freedoms. And so there's a cost and benefit to weigh how much should we interfere or intrude the protection of personal freedom. And there's also an initiative started in Obama administration. Because of time limit, I will not elaborate that. That initiative is still continue on. WHO joined that, the global health security agenda. One big challenge we face in this post-pandemic is, do we have a common future? What happened now and forward? And towards the end of pandemic, many countries, many scholars, many communities were talking about we need to have a resilient health system and, more importantly, resilient society. So I raised 3 important questions. Resilience for whom, for what, and in what? And moreover, to have resilience, we also need to incorporate compassion, innovation, and adaptation. So finally, what have we learned from this pandemic? I used the Zen enlightenment approach to respond to question with more questions. So our process of investigating, try to find answer for those 4 questions will help us better prepare for the future. Why did we allow it to happen? And why there are so many deaths from COVID-19? And how should society respond to major crises? And lastly, what will be the future of the world community? Are we going to be a world community or a world of villages? Thank you very much.